Hello, everybody. We're going to talk a little bit about addiction. This is about 1 hour session. It will provide an overview on a few pearls of addiction. Over the past decade, I've become less judgmental. I've learned that this just makes us bitter and it doesn't help our patients. Remember that most bad behaviors begin with good intentions. Again, most bad behaviors begin with good intentions. So, in overview, we're going to talk about what addiction is, the neurobiology of addiction, DSM, screening, and recovery principles. So, addiction is complex, it's often chronic, yet a treatable disease. It's very expensive, spending $7 billion annually on the condition. There's always the potential for exacerbation, recurrence, just like any other chronic condition. We know that there is a brain alteration in both structure and neuronal networks, and these changes persist well after that substance use or activity has stopped. We know that that moral compass is removed in favor of satisfying the reward system. So this helps us understand why patients relapse. We know that adolescence is an at-risk period. We know that treatment needs to be readily available, that no single treatment works for everyone, and it takes time, often months or years. If that treatment is not readily available, we haven't lost opportunity. So let's take a little look at history. We know that drugs of abuse are derived from plants and have been used for thousands of years. For example, there's evidence of use for alcohol and opium poppy centuries BC. South Americans chewed coca containing cocaine for centuries. We know that many substances of abuse are actually natural insecticides. For example, caffeine, tobacco, cocaine, opium poppy are natural pesticides secreted by the plants themselves to protect the plant. If you look at the picture, you can see a picture of a drug den from the 1800s. So what's happened? Well, we know that heroin purity in the 1930s was 12%. In 2014, it was 40%. And actually, it's 100% bioavailable when it's injected. So that picture, morphine was actually big business, and it was used for pain and sleep. We know that the British sold morphine to China at one time. Up to 25% of Chinese men were opioid dependent. It actually caused wars. For example, in the Civil War, when morphine was used, we called those using morphine having something called soldier's disease. We know that Bayer made and sold heroin to traveling salesmen. It was sold in catalogs for decades, quoted as, quote, non-addictive morphine, unquote. For 10 years, it was portrayed this way. And consumers loved it because of its rapid onset of action. Cocaine was used as a nasal decongestant. It was used for depression, for sleep, for diet. So what happened? Well, chemists isolated the active ingredient and it became more potent. So let's take a step back. What is normal? Well, the brain is like fingerprints, and no two are alike. Our personal experiences shape our brain, the choices we make, the fun we have, the stability in our lives, but also trauma, disease, and addiction. Our endogenous reward system allows us to enjoy things that bring us satisfaction, reward, and pleasure. Our limbic system of the brain allows us to have an incredible range of experiences. Music, food, sexual experiences, nature, vacation, they all provide us with brief surges of dopamine. But drugs of addiction lead to brain stimulation that's much more intense than we were ever intended to have. And this leads to those neuronal changes of the brain, both structurally and functionally. That pull towards drugs or any other substance that or activity that we use and become addicted to is at the expense of all other interests, whether it's health, work, family, life itself. The brain develops a pathological form of learning. In addition, society flirts with addiction. TV, gambling incentives, we use it to promote performance, and we use addiction to wind down. There's also reduced stigma. Here are some quotes. Every person I know that used to use pills now uses heroin. People that I never thought would even try heroin are now shooting up. And another quote, I knew I liked it above all else. And once I had a drug dealer, it became almost too easy. And I'm from an upper middle class family. So let's look at 4 individuals and through this session see what happened. Isabella. She's a 42-year-old female successful banker. Changes in work performance were noted. She was coming in late, losing weight, her house was messy, clothes all over the place, no food in the house, bills unpaid. She does alert her friends, calls her dealer often, and aimlessly paces. Isabella used Adderall to give her an edge at her 18-hour day. This escalated to cocaine. She was fired, lost friends, went into debt, and eventually didn't enjoy the highs so much and became depressed. Over time, her whole life focused on cocaine. She forgot how to problem solve, forgot her old way of life. Keep in mind that heroin and opioid relationships are not good relationships. When we look at neurobiology, you'll be able to see what was physiologically happening to Isabella. Damon's 28. He has opioid use disorder and early remission. He's repeatedly late for counseling appointment. Finances are, quote, bad. His relationships are unstable. He's having difficulty with his part-time job. He's having ongoing cravings and has trouble planning anything. Damon has prefrontal cortex changes, making it difficult to plan and prioritize. So let's look at Rhonda. Rhonda had gastric bypass surgery. She now has a gambling disorder. So Rhonda's experiencing addiction substitution. Harry can't sleep without his marijuana. He also uses it when he's bored. Harry likely has withdrawal from cannabinoids, and we'll come back to that boredom issue later. Remember that first decision is free will, but freedom is diminished and taken away after that. So here we're going to look at addiction stages. There are many ways of looking at that, and here are just 2 ways. On this slide, we're mainly going to look at A, but A and B here go hand in hand and are very complex. Our next slide is going to look at B much more closely. But if we look at A, that initiation phase, this involves some logic. Patients tell ourselves it's okay, no harm, it's pleasurable, and others in our circle approve. If we get down to lifestyle changes, we can see that here lifestyle commits to use. There's high use of defense mechanisms, and impulsivity changes to compulsivity. We have loss of employment, loss of money, family, good habits. We have negative emotional states without the substance, in essence withdrawal, and social changes. Things may go missing. The law enforcement agents will often say that patients stealing for drugs will often go straight to the bedroom, take the pillow out of the pillowcases, and find jewelries to put in that pillowcase and quickly exit. So if we go down to the breakdown stage, we can see that the previous way of life breaks down. The person with addiction is constantly seeking that next dose of the drug until they either seek help or die. And we're going to look at the next slide for B, binge intoxication, withdrawal negative effect, and preoccupation. So here we have 3 stages of the brain. You can see 1, 2, and 3, and they're color-coded. Basal ganglia in blue, extended amygdala in orange or red, and prefrontal cortex in green. And the areas of the brain there are highlighted. But if we look at 1, we can see the basal ganglia. There's the persistent desire to use more of the substance or have more of the addictive activity. And then this cycles around where we go to 2, the extended amygdala, where tolerance and withdrawal, compromised social and recreational activities occur. With 1 and 2, these areas constitute the primitive areas of the brain, primitive reward system. And these parts of the brain don't consider consequences. There's no reason. Remember that amygdala is a part of the brain that's the emotional realm of response. If we move up to the green, we can see the prefrontal cortex. This again is where deliberate and sophisticated activity of the brain occur, but remember, it's being hijacked. Go back to Isabella and Damon. These areas of the brain are becoming hijacked, and they continue to have that preoccupation of performing that addictive activity or obtaining that substance of abuse. So here we're going to look at salience reward pathway. And remember, salience is an extreme wanting or craving for something. So we have 3 parts of the brain that are involved in processing reward: the VTA, nucleus accumbens, and prefrontal cortex. So we have pathways from this VTA to the nucleus accumbens, and this is called the mesolimbic pathway, and also from the VTA to the prefrontal cortex, and this is called the mesocortical pathway. And we have dopamine released from that VTA to both the nucleus accumbens and prefrontal cortex. So why are addictive activities and addictive substances such as tobacco, caffeine, marijuana, and opioids so addictive? Well, at that VTA, this is where dopamine neurons originate here in the midbrain. And all addictive substances activate VTA neurons and subsequent pathways. So we have a large release of dopamine that creates 1, an initial rush and eventual craving, and 2, it also signals the need for learning. Unfortunately, it's a pathological learning, but nevertheless, the neural pathways are strengthened. Remember, from that midbrain, we also have a release of glutamate, and this is how that pathological remembering and learning is strengthened. So over time, reward is linked with triggers such as matches with tobacco, maybe the smell of marijuana, or maybe the location and time with using or performing an addictive activity. We call this people, places, and things, and these triggers remain long term, often well after that substance of abuse or activity of addiction has ceased. So let's now go to the nucleus accumbens. Here we have the pleasure center of the brain. And drugs of addiction actually overstimulate this nucleus accumbens, regardless of the agent. For example, there are extensive opioid receptors that opioids attach to in this reward center that trigger an increase in release in dopamine. In rat studies, if allowed to self-stimulate this area of the brain, they will do so in lieu of eating, sleeping, or mating. There's a however. However, repeated overstimulation of these reward circuits actually numb that nucleus accumbens function, and this is why patients develop tolerance. So normally without addiction, the sunset, a good book, a good relational experiences, a hike, nature, a sport, or a course that we like activates this area. With addiction, these things take a back seat. Sometimes it may take years for these things to become pleasurable or to have that patient derive satisfaction from, for that to all return. This is especially true with musicians, writers, and artists who no longer find those things enjoyable after they've become addicted to an addictive agent or activity. So if we look at that numbing, remember the body is always seeking homeostasis. So it actually releases its own endogenous opioid, something called dynorphin, that actually inhibits the VTA from overexciting the nucleus accumbens. Thus, another reason for tolerance. Remember, endogenous opioids are released with stress, spicy food, and even exercise. So let's move over to that prefrontal cortex. This is the area that loses when addiction continues. And you all know this is where we prioritize and multitask and problem solve. We make decisions, focus, and regulate emotions. This area changes structurally. It's actually hijacked in order to favor those primitive parts of the brain, and we now have a new normal. Dopamine and addiction, the perfect storm. The remodeled neural circuits give extreme value to that agent or activity of abuse. We look at that first bullet. Craving and wanting are very different than liking. Dopamine is associated with craving, but not liking. Let's think of the smoker. They may not want or even like to smoke, but they crave it. Craving is linked to the VTA. Liking is linked to the nucleus accumbens. And remember, the nucleus accumbens is getting numb. So patients may like it less, but they want it more. Over time, it becomes less pleasurable. So let's take a look at the reward system with sensitization. Over time, that reward system becomes less sensitized with repeated use, and it's easier to activate, kind of like the kindling effect. In cardiology, atrial fib begets atrial fib. The more atrial fib you have, the more atrial fib you have. With seizures, the more seizures you have, the more seizures you have. With mania, mania begets mania, and the kindling effect is almost irresistible. If we look at associative learning, it's kind of like classical conditioning, where environmental triggers become associated with using people, places, things. That drug dopamine release imprints that something important has happened and it's learned, and this is linked to glutamate release. So if we go back to Isabel and Damon, their brain became less responsive to sharp increases in dopamine, but cravings increased, creating tunnel vision where nothing else mattered. Over time, they lost health, family, relationships, money, time, and other things, and eventually their own self. There was reduced self-control. So if we look at reinforcers, we can see a primary reinforcer would be euphoria and to eliminate cravings, where a secondary reinforcer might be conditional cues, and that might be people, places, things, environmental triggers, with avoiding withdrawal symptoms and avoiding dysphoria. So let's look at genetic connection. So we know that not all who use substances are equally likely to become addicted. Geneticists perform leakage analysis with large families with addiction, and they examine genes on DNA strands that are near each other, and they're looking for polymorphisms that are associated with addiction. We know that there's no single addiction gene. There are several per these linkage analysis studies. We know that the same genes often contribute to separate addictions, and we also know that there's an interaction among multiple genes that leads to an overall addiction susceptibility. And that's why we worry about patients with addiction having addiction substitutions. So if we look at the reward deficiency syndrome, we see that these folks have a genetic variance. It's actually the A1 minor allele of that D2 receptor. They need more stimulation to experience the same level of reward satisfaction than those that don't have that variance. They're drawn to drugs to help stimulate a subdued reward circuit. So we know that dopaminergic polymorphisms are linked to multiple addictions, personality disorder, aggression, autism, and even the frustration tolerance that we all have. That last bullet looks at the fact that genetic makeup can affect why some drugs work for some of us and not others. If we look at naltrexone, we can see that those with the genetic variant associated with a strong pleasure response respond very well compared with those with a weaker pleasure response. So here are some stories from my own practice. I had a single Vicodin at 17. I thought, this is what's missing in my life. A second person, the person feels really good when they use for the first time, like nothing else, and they want to feel that way again and again. One is too many, 1,000's not enough. You may have heard that before. Okay, if I can't have Adderall, can I just have Xanax? Again, addiction substitution. Kyle was a patient who was told to leave the area because he had too many triggers at one location. However, in therapy, he had told us that he could be at any airport in the United States. He thought any airport in the whole world. And within 5 minutes, he could find somebody that would sell him drugs. It's almost like patients of addiction develop a certain intuition as to where they can get drugs and who can give them drugs or substances of abuse very quickly. So overall, many initially are just seeking a recreational outlet, and it just goes haywire. So is there an addictive personality? Well, we do know that there are certain traits that are common. In some, they may have childlike behaviors. I want it and I want it now. I'm not doing it and you can't make me. They often have low self-esteem. They often use an external locus of control, depending on external events to guide their decisions. For example, an empty bottle, they'll stop. When the bar closes, they'll stop. When the paycheck is gone, they'll stop. They often don't want to process negative states. They avoid and they self-medicate. They often have a heightened sense of stress, difficulty waiting, and a desire to feel different. Use of defense mechanism. Well, there's a long list and we all use them. We use them for self-protection to keep us from fully experiencing reality, to cope, to maintain image, to reduce stress. Use of defense mechanisms is very common with addiction, and they can and often do become maladaptive. For example, denial. Fine, I'm not hurting anyone, etc. Well, they're often unable to weigh the risks and benefits with denial. There's an inadequate fear of danger. If we go down to projection, for example, the alcoholic wife pointing out her husband's gambling effect. With rationalization, everyone else does. I want to be social. You're not home. You make me crazy. No, you drink because you're an alcoholic and you need to take responsibility. Patients with intellectualization often divert their attention from talking about a negative aspect to engaging in something else. For example, a patient using marijuana daily may neglect the impact of his daily use by engaging in a discussion about the legalization of it. From a pathological standpoint, all of the defense mechanisms can lead to manipulation, lying, cheating, stealing, etc. Patients often may minimalize, which is straightforward. Age, trauma, and addiction. We do know that the earlier a substance or activity is started, the higher likelihood that this activity will continue and become pathological. We know that unresolved trauma can quickly blossom to addiction. Genetics plus early life experiences can set the stage. So earlier stressors, abuse, act on those same stress circuits in the brain as addiction. We know that as high as 80% of drug users have had some form of trauma in early childhood. These brain changes increase vulnerability, and sometimes they are permanent. So trauma can leave scars. We use them to cope. Patients have used them to cope. And we've learned to ask, as I've said before, instead of asking what's wrong with you, we've learned to ask what's happened to you. So the DSM uses the following descriptions criteria to classify symptoms for diagnosis. This is likely a review, but I'm just going to cover it very briefly. So substance-related and addictive disorder, DSM-5. We have that triad of abuse, dependence, and craving. Other clinical features have included loss of control, progression, and denial. But you can see here with substance use disorder, we have impaired control, social impairment, risky use, and we have pharmacological criteria. With substance-induced disorder, we have intoxication, withdrawal, and other disorders that may have been induced by substance use that might be anxiety, psychosis, and sleep disorder. And then the only non-substance related activity that the DSM mentioned is gambling. It doesn't mention internet binging or sexual addiction. For binge eating, this is in a separate area under feeding and eating disorders. So with substance use disorder, we have 11 criteria where patients would use larger amounts. They are unsuccessful in stopping. Lots of time is involved in using. They crave and they fail at other roles, and they fail socially. This process doesn't happen overnight. This compulsive use leads to loss of control. So what happens is one narrows their choices on a daily basis in order to accommodate that drug seeking and drug use behavior. Many patients enjoy the process of preparing for that addiction, whether it be an activity such as gambling or whether it's the high from drugs of abuse. So as you know, we also classify substance use disorder into the categories of severity, and we have separate specifiers, mild, moderate, and severe, depending on the symptoms that the patient displays, and also specifiers, whether it's in early or sustained remission, or whether the use is in a controlled environment, such as the prison setting. So the opioid cascades, how do patients present? And the answer would probably be no two the same. They often have no symptoms, and that's very common. Initially, many have a low perception of risk, and this low perception of risk plus easy access is a recipe for an ongoing health problem. So they may have symptoms listed there. You might want to look at their pupils, look at the use of defense mechanisms, needle marks. Remember, pupil constriction might suggest intoxication. look for scabs, anything like that, or they may have the opioid effect, some euphoria, some constipation, or they may actually even be in early withdrawal when you see them. But you can see that they're opposite: euphoria with the effect and dysphoria with withdrawal, constipation with the effect, and perhaps diarrhea with withdrawal. Um, Analgesia, so there's pain relief with the opioid effect, and they may actually have muscle or joint pain with withdrawal. So any of these things patients can present with. But if you imagine the worst flu you ever had and multiply this times 10, and this is what withdrawal can feel like for these folks. And it may take 3 to 7 days for withdrawal to occur, 3 to 7 months for that craving to diminish, and it may be even up to 3 years before they enjoy things that they once enjoyed without using. So this may be a review. This is what you may see in practice in lieu of them presenting with some form of addictive disorder. You may see these things listed here. They often go to great lengths to hide their addiction. And remember, polysubstance is the norm. So, for instance, those using opioids may also use cocaine and alcohol. So, we're really looking for progression, an increase in dose and frequency, route of administration, tolerance, withdrawal, complications, and functional impairment. So the COWS, you all know this, it looks at the pulse rate, sweating, restlessness, pupil size, runny nose, achiness, joint achiness, GI symptoms, tremor, yawning, anxiety, and skin. It can be used inpatient. It's often used in buprenorphine clinics during the induction. However, in primary care, we would use most likely the H&P to identify any withdrawal. So a few words about marijuana. So most in the field of addiction would say that daily recreational use is probably not a good idea. Well, maybe the ones making money from it. Well, a generation ago, very few of us thought that marijuana was a good idea. Now about half of us do. Now this discussion is not discussing medicinal use. That is a completely different talk. Where therapeutic uses are 1 to 2 intakes per day. This is recreational use. The concern is especially for those in 9th to 11th grade. Remember, these folks are studying for their SATs, they're enhancing skills and relationships, and we know that regular use curtails IQ about 8 points. So this can be lifelong effects if they're not studying for the SATs and not preparing for the future. They go on to an attitude of the status quo is okay, and long-term goals are affected. The term couch potato came from the 60s when we had regular users of marijuana. We termed it hippies of the 60s. They kind of developed an amotivation syndrome. They were satisfied with the status quo, a slight apathy, and never quite reached their full potential, nor were they interested in it. We also know that there are fat-soluble compounds in marijuana, so it's lipophilic, so the effects can remain for weeks, if not months. And there is some association that it may be a gateway drug to more intense drugs. Having said this, many of my patients use marijuana all the time, and I just have to live with that, and they do too. The APA has a scientific statement that there is no evidence that it can be used as to benefit any psychiatric disorders at this time. Now we're going to learn more about the endocannabinoid system, and this may change. So cannabinoids. So we did not learn about the molecular biology of cannabis until the early 1990s. We learned that the endocannabinoid system helps prevent aversive experiences from overwhelming us. We know that these endocannabinoids regulate neurons that communicate signals to neurotransmitters: glutamate, GABA, serotonin, dopamine, norepinephrine. We know that the endocannabinoids buffer neurotransmitter activity, mainly glutamate, and it slows things down. We do have a natural ligand, and that's anandamide, and it binds to both of these receptors, CB1 and CB2. So CB1 is expressed in the central nervous system, and here we have those psychoactive effects. And the CB2 receptor is expressed in the immune system. So we know that this anandamide binds to both of those receptors. So cannabinoids help us forget what we don't need to remember: previous directions, a parking spot, a phone number that's not needed anymore, previous patient information. Otherwise, this information would interfere with new relevant information that's needed. So we know that cannabinoids are critical to unlearning and to fear extinction. So if we go over to the right slide, you can see the exogenous cannabinoids, THC, the psychoactive component in cannabis. This becomes the endogenous ligand, a partial agonist of CB1. It floods the system indiscriminately and it affects memory and information processing. If we go down to the bottom of the right, we can see that synthetic cannabinoids, these are full agonists of that CB1 receptor. They're legal highs. They can be still purchased online. Initially, they were used in research lab to explore medicinal uses, and K2 and Spice are examples, but these are very potent. These are the folks that you see with psychosis in the ER, where even antipsychotics sometimes don't work initially. Another thing, that they are not detected on standard drug screens. And as with the others, they enhance the activity in that reward system and stimulate the VTA, just as other substances of abuse do. So here we have effects of THC on brain structures. And you can see that receptors are dispersed all over the brain. This THC mimics that anandamide, attaches to the cannabinoid receptors, and you can see the wide range of effects that it might produce. Whether it is memory impairment that affects the hippocampus, or impaired coordination affecting the cerebellum, increased appetite due to the effect on the hypothalamus, slowed reaction time, where everything slows down, is due to the effect on the basal ganglia. And the cortical structures are affected. This is where we have changes in judgment or perception. And we have effects all over the brain, that of euphoria from the effect on the nucleus accumbens, and the affective signs, whether it's anxiety or paranoia, from the effect on the amygdala. So look at this slide more closely and you'll be able to see that on your own and visually. But again, there's a wide range of effects. As far as enhanced visual and auditory perceptions, food may taste unusually good. Music may sound very beautiful, scenery fantastic, sense of time slowed down. At higher doses, we have paranoia, anxiety, and agitation. Our inhibition is lowered, but you can see why all this happens. So here we have more on marijuana: short-term effects and long-term effects. Short-term, we may have impaired judgment or impaired memory, reduction in IQ, more accidents, some paranoia. Long-term, we have risk to potential, underemployment, chronic stress, missed potential. There may be more anxiety in the long run, more cardiac, respiratory conditions. There's always that addiction pathway that we're always concerned about with any addiction substitution. There are some proclaimed benefits, which include patients agreeing to just use marijuana. and not go up to other substances in pain relief. Now remember, medicinal use is very different, but many of our patients are going to use marijuana. Many of them are going to use it daily, and we have to look at it as a one-on-one or an individualized approach on how to help that patient most. Having said that, marijuana is often used as an antidote to boredom. It makes the mundane things exciting and novel, whether it's being a busboy or a security guard or sitting in a classroom. The problem is after use, patients don't know what to do when they're bored. They often miss the psychological work that's needed to achieve goals. If they're using it to relax and sleep, what happens after regular use is they can't sleep or feel calm without it. They actually experience what's called a cannabinoid deficiency state or withdrawal, and it's just a roller coaster of symptoms. By the way, withdrawal symptoms may include sleep dysregulation, craving, irritability, anxiety, some depression, and decreased appetite. Let me ask you, why is it a good thing that there are no cannabinoid receptors in the brainstem or the medulla? And that would be because there is no risk for respiratory depression. Having said all this, from a psychiatric nurse practitioner point of view, remember that since marijuana affects all other neurotransmitters, it makes treating conditions that use medications that alter neurotransmitters suboptimal and inconsistent. And that's the take-home message. Cannabis gummy bears. You all may get these emails, but this came to me the other day. You can see it advertised with all its proclaimed benefits. And we'll probably see lots more of this in the future. Just have to keep an eye on recreational use. We know from a scientific standpoint what has happened. Again, this research is only coming on less than 20 years old. We'll have to follow it. But again, the APA sees no benefit of any psychological condition with using cannabis as a treatment option. That's where we're at in 2018. A few words on alcohol. So initially, alcohol binds to the GABA and the NMDA glutamate receptors, thus enhancing GABA effects while at the same time inhibiting glutamate effects. So over time, the brain compensates for the overstimulation of GABA receptors that alcohol causes by producing more NMDA receptors, upregulation. So the overstimulation of GABA receptors causes downregulation of GABA receptors while at the same time upregulation of the NMDA receptors. So the problem with stopping alcohol is that it's not then there to inhibit the excitatory neurons, thus the glutamate neurons, and we are at risk for seizures and exacerbated anxiety. Moving down the slide, over 10 million of us are dependent, and many have no idea that their drinking problem represents a pattern of dependence. They may present being tired, nervous, they may have weight loss or insomnia. So we need to ask these questions judiciously. So many alcoholics have periods of sobriety that falsely reassure him. One definition of a non-alcoholic is not whether he can abstain for 30 days, but whether he can stop at one drink per day for 30 days. If we go to alcohol abuse, this is when alcohol means more to the person than the problems that it causes. In reference to those questions that we might ask about morning drinking, or for example, tremor. We may look for defensive mechanisms being used, and also about family history and relationships. When I mentioned that every organ in the body is affected on the slide, we can see that it's poisoned. Cells are poisoned by alcohol. This can result in anemia, low white blood counts, increased uric acid level, muscle aches, skin changes, spider angiomatata, esophagitis, increased cholesterol, triglycerides. We may have arrhythmias, PVCs, and some hypertension. In reference to withdrawal, hand tremors can be an early sign, sometimes the earliest sign, while late signs, subtle signs, may be an inability to sleep, and worst case, perhaps tactile hallucinations, where patients actually feel things on their skin that aren't there. With high-level withdrawal, we need to use benzodiazepines, usually for about 5 days, to alleviate any serious concerns such as high-level anxiety and seizures, and also comfort measures. So a few words about dopamine. While all drugs lead to a release of dopamine, stimulants increase dopamine directly. They affect the cell's transporters. So we know that in knockout mice, when dopamine neurons are destroyed, these mice will stop administering the stimulant. We've learned that high doses of dopamine in the stimulants can lead to stereotypic behavior and psychosis. And these behaviors might include body rocking, crossing and uncrossing legs, marching in place, and eventually the psychosis, paranoia, and tactile hallucinations. We know that many folks are using these agents as performance enhancing agents. And this can be risky depending on who's doing it. Do we want to use drugs to do better at work, school, for increased energy? If they have the genetic profile to escalate, this is not a good thing. Methamphetamine, we know that this is how powerful it is. After 6 months of rehab, 90% have been shown to relapse. So we need to look at relapse as a learning opportunity in these patients' journey. If we look at cocaine, we know that there are changes in the structure of the prefrontal cortex neurons, and there's decreased activity and volume just within a 1 month period after that cocaine is initiated. And the ability to override that craving weakens quickly with a short period of time. As an aside, with amphetamine abuse, I should say, so after that high, the euphoria will come down within 2 to 3 days. Sometimes they will then go on to have a refractory depression. Symptoms can last for 1 to 3 weeks. Pathological gambling, you can see the DSM-5 criteria listed. You can see how expensive it is, but essentially, looking at the DSM, these folks can't stop, and it's affecting their life. We know that moderation is rarely effective, and patients must grieve the loss. They enjoy gambling, and they actually grieve this loss. For decades, pathological gambling was considered an impulse control disorder. However, now it's under the behavioral addiction component. But gambling uses the same sites of the brain. These same areas are activated as with any other substance of addiction or activity of addiction. They're seeking that dopamine fix. Remember, over time, that nucleus accumbens is getting numbed, decreasing the reward response, so patients will gamble more to get the same level as excitement that they did previously. They actually have withdrawal symptoms: restless, irritability, insomnia, and headaches. And research has found that patients with Parkinson's disease and restless leg syndromes who are taking dopamine agonists are 3 times likely to become pathological gamblers. That would be like ropinirole or Requip. About 15% of patients taking this drug end up with this behavioral condition and gambling. So how do we treat this? Well, the same way as other addictions. We use CBT and 12-step program. We do know that naltrexone competes with those endogenous opioids and blocks the euphoria that's associated with gambling. So that has been used for pathological gambling. So let's look at some other addictions. We can look at food, sexual addiction, internet addiction, shopping. Historically, food in general was limited, and high-calorie foods were a luxury. We were meant to want them because they were so rare and we craved them. Provocative stimuli was rare, even nudity. There was no internet, only hunting, and we rarely caught something, and shopping was very sparse. So, all of these activities hyperstimulate that reward system. They fill a void, a reality escape, and they're enjoyable and satisfying for some folks. If we go down to sexual addiction, you can see some of the things listed there. Pornography, a 9-year-old is now exposed to things that my grandparents and your grandparents perhaps have never seen. A lot of our searches on the internet are sexual. There's a lot of child pornography on there. We know that video games are a huge moneymaker, and many young people are very addicted to those things. Shopping is often used as an addiction substitution. I had mentioned before where I have had some patients who have had gastric bypass surgery who are now gambling a lot to fill that void, or shopping a lot. So treatment, we need to recognize, accept the problem. Patients need to decide to change and commit to healthy relationships and ask themselves what are triggers that lead to the desire, and look at some healthy addiction substitutions. These are all things that we're learning more about, and they are a problem often in middle to upper class families. These have an association with substance use disorder. So in any patient with substance use disorder, you would think about also having these things, and at the same time, any patients with these disorders considered substance use. Also want to consider substance use disorder when patients present to you who are not getting better with the conditions listed. So why is there this association? Well, we know that there's perhaps a genetic susceptibility. We know that patients may be trying to self-medicate and using these agents as using substances as a way to cope or escape, or that the substance is causing the comorbidity. For example, stimulants may lead to anxiety, and benzos may lead to depression, and marijuana may lead to insomnia. We also need to consider infection risk: HIV, hepatitis, TB, syphilis, endocarditis, all associated with substance use disorder, depending on the agent used and the method of intake. So we know that there is an overlap between ADHD and substance use disorder. We know that it's likely multifactorially linked, and that there's related neurobiology between the two conditions, mainly in that novelty-seeking genes that influence the likelihood of both. Again, it's a variant of that D2 or D4 receptor genes. So we'll pay attention to that more as we move forward. So the estimated odds, those with ADHD are likely to use. So the higher the odds ratio, the higher odds of use. You want to consider ADHD in any young person with substance abuse disorder. Treating ADHD helps decrease later substance use disorder. So if you have both going on, you want to treat both conditions simultaneously. So this study is looking at college use. Those using illicitly are more prone to using other substances. Overall, about 4 to 16% use without a prescription. They use it to gain attention, to study for tests, to stay awake, to party. Interestingly, there was more illicit substance use of ADHD medication in schools in the Northeast and in those with higher admission standards. I thought that was interesting. So here you can take a look at this. The medical conditions in patients with opioid use disorder. You can see them, the organ system and the complication listed system by system. Just take a look at that to clarify. And then here you have comorbidities with alcohol addiction. Again, organ system and then early and late consequences. And this is medical comorbidities. So now we're moving on to screening. So you want to screen every patient. This is in primary care. You want to screen every patient over 12. In our settings, it may be even lower. But again, remain non-judgmental. You can use your validated questionnaire test, or in psychiatry, we kind of just use our own open-ended questions. Tell me more about your alcohol abuse. Remember, laboratory tests, random drug screens are routine in a lot of settings, and you should always, as any provider, primary care or psychiatry, be familiar with signs of withdrawal and recognize that substance use disorder is always often comorbid with other medical conditions, dual diagnoses. So in your interviewing, when you're looking at history and screening, you want to ask these questions. What age did you begin? How often have you used in the last 6 months? What problems have you had? Are your friends using? What substances are you using? And in a comprehensive assessment, this is when you're trying to disdain a diagnosis. You want to determine the extent and also look at what treatment may be needed. So you're going to look at age of onset, choice of drugs, functional value, all these things listed here. In essence, you want to see if there's problems at home, work, and school. So if a young person denies using, sometimes I'll ask them, have you ever driven in a car with someone who's high, just to get the ball rolling or evaluate the risk. In primary care settings, the NIDA drug tool is often used again and again. The tool measures substance and frequency. Again, in primary care settings, you would expect use of defense mechanism. This is in psychiatry settings also. And the EMR may dictate what tools are used, at least which ones are there and not added onto your own personal evaluation. So what about drug screening? This too is going to depend on your settings. You may do random testing. You may do it on patients who have a history of drug use and also those who aren't responding to treatment for another condition. Usually the urine drug test is the most common. Remember, true false positives are rare. Sometimes we do need confirmatory testing. And again, use positive drug testing as an opportunity to begin discussion on therapy, on coping mechanisms, on medication-assisted treatment, etc. That can be the beginning of a new era in that patient's treatment. So listed there on the side, that is a Whizzinator. You can get it online, and it is used to create fake urine. It even has a heating device, and that one is for about $140. So sometimes what I will do is at the end of the visit, I'll sometimes say to my patient, I'm going to get a urine drug screen today. Is there anything you forgot to tell me? Okay. So in these drug testings that we do, the basic test is an immunoassay. It's an antibody test. And confirmatory testing is chromatography. So remember, alcohol testing is not in the routine urine drug screen. We would do this separate. There are some new screens that measure metabolites. False negatives are much more common. Oftentimes some benzos, specifically lorazepam and clonazepam, are sometimes not detected. Rarely false positives can be shown, for instance, quinolones with opioids and selegiline with amphetamine and sometimes some other things. But in a basic urine drug screen, we check for amphetamine, cocaine, THC for marijuana, some opiates, and phencyclidine. In a comprehensive test, this might add methadone, some other opioids, and sometimes additional benzos. So a blood detection time is 6 to 12 hours. So a blood test would only detect recent use. As far as urine testing, that may be detected 3 to 4 days after use. Hair may be 7 days to 3 months. So that, in essence, would not tell you about recent use. And remember, it takes about 2 to 3 hours for most drugs to concentrate in the urine. Patients often try to dilute it. They add salt, aspirin, Visine, Drano to remove substances that are truly in there. For instance, hydrogen peroxide may remove THC or some opioid. They have all kinds of things that they will try to do. So here you've heard of SBIRT. The S is for universal screening for everybody. BI is a brief intervention for those at moderate risk, and then referral and treatment for those at severe risk or active substance use disorder. So these are great tools for primary care where many are not at high risk. So now on to recovery. The patient must decide to stop. And choice is very important. They must choose. You can't make them stop. We as nurses often overinvest in our patients when they're not ready. They must recognize that it's hard. It's hard work. It's stressful both psychologically and physically. They have to grieve loss of their friends, environment, and the high. Something must give them a new high. For some, it's I've had enough. For others, it's a new goal. For others, it's meaning. And others, it's maybe a new faith in God. There's often triggers that we talked about, and triggers to relapse may be stress or people, places, things. Oftentimes, patients with addiction will develop rituals in preparation for their next use. In reference to overdose, why do they overdose? Well, they're sometimes prescribed higher doses than they intended to get, multiple treatments at the same time, a new dealer, opiate naive patients after detox do not need that high dose that they had before detox, and now that is just too much and receptors are oversaturated. Drugs are often laced now with fentanyl. There may be other conditions present, comorbid disuse, or they may have a benzo add-on. It takes time. The susceptibility can remain years later. I have one man that I saw in the last months, and he had not used heroin for 25 years. And he tells me very sincerely that if he were with the group that he was with before, in the same environment, in a weak moment tonight, he's not sure if he wouldn't use again. Our current U.S. president, his brother was an alcoholic, and our current president won't touch the stuff because he fears that addiction potential. So here you can see when we're looking for treatment of drugs, we want to develop drugs that will target these areas, whether it's the reward salience pathway with the VTA and that pathway, whether it's the hippocampus and extended amygdala for learning and memory, or whether we're up towards that prefrontal cortex for motivational drive and inhibitory control. But all of these regions can be considered when we're developing strategies to effectively treat addiction. So simplified, drugs attach to receptors and mimic neurotransmitters. The receptors are made of protein, which are made of genes. So every time we identify a gene that contributes to addiction, that gene becomes a potential target for a biologically based treatment. This is the same with other diseases. One problem we have in treatment today is we still want folks to enjoy the natural pleasures in life, but selectively avoid the consequences of drug addiction. And so far, no drug has been able to do this. This quote is just interesting to what we're talking about today. For every complex treatment problem, there's a simple solution, and it's wrong. This is similar to the concept is easier than its implementation. Those two quotes have just haunted me and followed me everywhere I go in my nursing career. So here we're moving to medical treatment. We have abstinence-based versus medication-assisted treatment. Patients must hit rock bottom for abstinence-based to work. The light went on, there may be a spiritual component. They often will quit cold turkey. They go through a terrible withdrawal. They need close follow-up because there's a very high rate of relapse, so they need to be extremely motivated. Statistics have shown it's very difficult to do. They need a strong support system. Some have done it though. If we move on over to the right side, medication-assisted treatment, it's not perfect, but you can see the drugs listed there. We do know that it's associated with less death, less hospitalization, and some normalization of other aspects of life. We do want to make sure that we don't let perfect be the enemy of good, because this has helped a lot of folks. Yes, there's some diversion of these things, but having said that, we've kept a lot of people working at home with their children, and to the point where others don't even know that they're using buprenorphine or Subutex. So medications used to assist treatment, MAT. Let's start with methadone. Methadone is an opioid with a long half-life. Patients experience less euphoria than they would with other opioids, and it has been shown to reduce cravings and withdrawal. It's best for long-term addicts, those who have diverted before, those who you want to watch, but remember, these folks have to go to the clinic often. Buprenorphine, it has a high affinity for the mu receptor, so it will block morphine and methadone from those receptor sites. It has a high affinity, again, for the mu receptor, a partial agonist at the mu opioid receptor site. So Suboxone just combines the buprenorphine with naloxone. Why is naloxone added? It's added to deter diversion. It reverses the effects if that opioid is taken intravenously. If it's taken orally, it's just not absorbed. Again, there's less euphoria, less physical dependence, less potential abuse with other opioids, and it also decreases cravings. Both methadone and buprenorphine definitely decrease heroin overdose and death. They also decrease HIV and hepatitis C. As far as abstinent treatment, some folks will see this, Suboxone and methadone, as pseudo-recovery. However, we're going to talk on the next slide about harm reduction and how it's used in medicine and nursing. Buprenorphine also has a very mild withdrawal profile, so this helps patients stay in treatment. Naltrexone is another drug that we use. It's an opioid antagonist, decreases craving. There is no euphoria for them, and patients must be motivated because they don't have the euphoria that they may have with some of the other drugs such as buprenorphine and methadone. But naltrexone is good for patients who cannot have a positive drug screen at their work. They need 7 to 10 days of abstinence first. It's hard work, and it will block the pleasurable effects. Again, why they have to be motivated. Side effects can include hepatic dysfunction, GI symptoms, and depression. So harm reduction principles. Reduces risk and negative consequences. You can see the examples here: needle exchange, supervised safer injection. Naloxone is a harm reduction principle. Hepatitis vaccination is a harm reduction principle, and so are Suboxone and methadone. But where do we use this and not even think about harm reduction? Well, we use it with sunscreen, we use it in STD prevention, we use it with seat belts, and we use it with helmets. But it allows us in opioid and substance use disorder to have more of a non judgmental approach. We're focusing on quality of life, celebrating positive change, and we use relapse as a learning tool, just as with any other chronic disease. It has been shown to be evidence based, cost effective, and save lives. And the quote there, if we run away from people who are struggling, then where are they going to find hope? And that's all part of psychiatric nursing. This is kind of a summary slide to the slide that we just viewed, and it's medication assisted treatment for opioid use disorders, but it lets you look at the pros and cons of using medication assisted treatment. We've talked mostly about the pros and some cons. Some folks don't, there is a stigma associated with it, and some feel that patients aren't taking a complete responsibility. But let's consider what they do in other countries. In England, Vancouver, the Netherlands, they're actually using heroin, prescribed heroin, as a harm reduction strategy where patients come in and get a prescribed dose of heroin so that they don't take higher doses off the street and overdose or develop those conditions we talked about on another slide in reference to infectious disease. Narcan is actually humane. It decreases deaths, and you wouldn't withhold insulin from a diabetic. Some cons about Narcan: I have had patients tell me if it was available 10 years ago, they would not have stopped. So it's kind of a mindset that we have. It's available, and until we have better treatments available, we need to use it. So here I have a slide that describes the clinical pathway for buprenorphine. Now, we're not going to talk about this step by step, but just an overview. Once the NP has the waiver, the patient would come in for an initial interview. They would get lab testing. They're required to have counseling and group therapy. The patients would come in opioid withdrawal symptoms, and we would use the COWS test to assess their withdrawal symptoms. And they need to be in about moderate withdrawal. And we prescribe the buprenorphine at lower doses to make sure they tolerate it and give them again. And then they go home and they come back the next day and we redo doses. Then we give them a week's supply. We see them weekly for 16 weeks. Frequently, we get urine drug tests every week that we see them, and we also do random tests. Over time, we do them less often. Remember, psychiatric comorbidities can complicate buprenorphine treatment. It can complicate the medicines and the priorities. We need to make sure that we're treating a drug condition and not a comorbidity, and vice versa. Patients do not use benzos when they're prescribed buprenorphine at the clinic. So they're tested randomly for drug tests, and we need to monitor their LFTs. Now, again, patients aren't perfect, and they do mess up, and it will depend on the clinic how forgiving you are. Sometimes it's one strike, two strike, three strikes, you're out. But patients are struggling. We're there to help them, but we also cannot enable them. Moving on to therapies, psychoeducation is important for the patient and the family. We address mindfulness, brief motivational interviewing, looking at goals, CBT always, 12-step programs are important to these folks. They will be treated by the nurse practitioner. They'll also be in group therapy, and they should have counseling. That's the ideal way to do it. Now, you will have these Suboxone cash clinics that don't follow the rules, and patients just pay cash. If you really want good treatment, which I hope you do, you want to have a good team-based, comprehensive approach with these patients. Family participation is important. We need to explain the dopamine fix, make sure the patient understands that they have a choice. understand nuances about the medications, address goals and barriers, make sure they know that it's hard work and they need to be ready to explore recovery. I almost expect relapse in some of these patients. It's a learning tool, and they need to learn that good relationships are most supportive in all this. So, assumptions about change. Not all patients want to change. Now may not be the right time. Patients sometimes don't want advice. Health is not a motivator for everyone. A lot of patients don't comply, and change can happen in small increments. Change has been hard since biblical times. Way back in Romans, there's a quote that says, "I do not understand what I do. For what I want to do, I do not do. But what I hate, I do. For what I do is not the good I want to do. No, the evil I do not want to do, I keep doing." It's not new. So this is straight from Washington. We think we want change, but then we don't want to change. So despite protestations to the contrary, Americans don't like change. You would think that while we might disagree about what kind of change we want, Americans are in total agreement that the current situation is intolerable in all areas and that change is essential. Americans do agree on this in the abstract, but as soon as it seems that change might actually happen, as soon as we leave the abstract for the particular, we panic, and suddenly we develop nostalgia for the comforts of the status quo. Sure, we want change, as long as everything can stay just as it is. Change is difficult. So here we have a case. A suburban wife began using opioids innocently, and this led to heroin. Her husband gave her a choice. She could not use it home or around the kids, but she could leave. She made the decision to leave. Then later, she made the choice to go to rehab. Pointers. We need to let patients know how much better things can be without addiction. Let them think of ways that life could be better, and they come up with the solution. It's difficult to detox cold turkey. Programs need to include counseling, faith options, nutrition, massage, exercise, a holistic approach. Her best chances at success are mainly with aftercare, after the rehab, tells us how well they're going to do. The key here is that she made the choice. Okay, we're getting towards the end now. I just want to spend some time with this slide, the bigger picture. Let's start with newer treatment options. TMS, transcranial magnetic stimulation. This is where a coil wire is inside a wand and it is used to stimulate the brain in areas responsible for inhibiting behaviors. It alters the electrical activity of the brain. We also have buprenorphine injections that work long term, so patients don't need to administer drugs daily. So if we move on to the second bullet, world circuitry, we can see that 99% of all criminality is due to money or drugs. So we need to cut either supply or demand. And we talked earlier about the trafficking pictures, and you're going to have subsequent slides with this. But remember, China sends to Canada and Mexico. Medications are laced, fentanyl, heroin. The fentanyl, remember, is 40 to 50 times more potent than heroin, and carfentanil 100 times more potent. In 2 years, we're likely to see much less heroin in the local area. So our chemists are in this dark, there are dark illicit chemists who are one step ahead of us. They're actually strategists, just like strategics in other companies, universities, and government. They're one step ahead of us because it's so profitable. Our hope is probably for the next generation, because we may see this worsening before it gets better. So just a few words about heroin. 2 or 3 milligrams is enough to kill. One stamp is called a bag, and that's $5 to $15. And 1 kilogram of heroin is about $60,000. So if I talk more about prevention, you can see we need to start early. We need longer rehabs and chronic care. We need parenting classes, and we also need places for children to go when parents are in rehab. Patients may need lifelong buprenorphine, and this is controversial, but it may keep patients away from further harm. Addiction substitution can be a good thing and it can be a bad thing depending on what's substituted. Uh, we may need, in the future, we're probably going to have the potential for vaccines and even drug patches that would deactivate the drug. Moving down to training, we need to have specific and better training for police, for people in prisons, personnel in prisons, teacher, and also clergy. Our protection services are overwhelmed. For example, nonviolent crimes, there's no jail. 6 to 7 bags of heroin possession may lead to only 3 to 6 month probation. Remember, a probation officer may have 100 to 130 persons he's responsible for, and a judge may see 20 to 30 trials per day, and the same thing the next day. If we go down to that final bullet, global models, let's look at Portugal. Portugal researched the high addiction rates. It actually ended up legalizing all drugs and took money from punishing people who were using and possessing and put that money into rehabilitation. And they actually found a 50% reduction in use. So they discovered that social connectedness was found to be the key to sobriety. And all this research started with a rat study where they had rats in a bear cage. And these rats were given a choice of plain water or heroin water. And the rats, for the most part, chose heroin. The experiment was done again in the cage was bigger and it had colors and good food and other rats and was more appealing aesthetically, and the rats ended up taking the plain water in lieu of the heroin. So let's look at trafficking patterns related to opiates. You can see East Africa, Afghanistan, Europe, South Africa, Canada, US, Central and South America, Australia, Iran, Turkey, Central Asia, Russia. The dark net allows this drug trafficking to happen. It's easy and it's anonymous. So in this slide, we look at trafficking patterns related to cocaine, where it's cultivated in South America, mostly smuggled through Africa or the Caribbean, then Europe, and stored in Costa Rica. And this information haunts me. It's a 5-sentence article from 1980 stating that addiction is rare in patients treated with narcotics. This alone contributed in part to the opioid crisis today, where 608 articles used this citation as evidence. In 2007, producers of OxyContin pleaded guilty to criminal charges, and that they misled regulators and doctors and patients about the risk of addiction. So this is one perspective. Let me give you another perspective. Several years ago, a nursing home wanted to reduce opioid usage, and they utilized non-pharmacological techniques such as massage and music and meditation and all those kind of therapeutic techniques. And families got together and actually sued this nursing home for not medicating patients with opioids. And so you can see many perspectives contribute to where we're at today. This slide allows you to see that we probably need to utilize a chronic care model when we look at addiction. We can see that there's big relapse, and the care that we need to provide these patients is continuous, and patients need to be followed, and we need to believe in recovery. So in summary, remember, addiction changes the brain and is powerful. Most concerning are those early years. Oftentimes there are dual diagnoses and we have lots of treatment available. Judgment doesn't help us and it doesn't help our patients. Recovery is long term, it takes time to change, and we need to look at different treatments for different patients. Group therapy is very important. Probably prevention is going to be key moving forward. 11 years old might be too old. We also need a balance of support and direction, providing care without enabling our patients further. So here we have the summary of the neurobiology of addiction before we move into the final summary. So we have a large release in dopamine into the reward system with any thought or initiation of an activity or substance of abuse. This leads to a strong association before the drug-related trigger and using, and this leads to stronger cravings. The chronic drug use leads to numbing of the response of the pleasure center of the brain. Remember, that's the nucleus accumbens, and this is how tolerance develops. And there is reduced self-control, and this is due to the weakened inhibitory input from the prefrontal cortex.